research department. And so I thought first I would introduce myself and then kind of go into some of my projects. Now, my hope again is to let you know a little bit about my research, but also to have you think about, depending on the role that you have at the hospital, perhaps is there something that you can take away from some of the things that I'm doing, or some of the concepts or constructs that I'm investigating that might influence your own practice. So is there something that you could do to apply it to what you're doing? Certainly as I go along, I really hope that if you have questions that you ask as we go. So please feel free to interrupt as we go. I know that on Zoom it can be tricky because of the delay, but you could either, do a reaction or in the chat, or just try to interrupt. I would greatly appreciate that. And then certainly if you have any ideas. So as I go through, I may at the end talk about sort of next steps. And so again, that's where I would love some input and thoughts about, again, how do we take what I'm doing, really make it applied as we can to influence practice and care for clients at our hospital. So for those of you who may not know, so I'm a clinical and forensic psychologist, and I showed up at Ontario Shores about 8 years ago. I'm a part-time clinician on FPRU, so a minimum secure unit in forensics, and was really the unit psychologist there. And I'm so grateful that I first had that opportunity prior to moving into research, because for almost 3 years, I got to see sort of on a front line the challenges or unique experiences of our clients, especially in forensics, sort of how staff work and challenges that staff face. And I've really used this to guide sort of where I've gone in terms of my own practice in research. And while I was doing that, I started off exploring research sort of on the side of my desk, so which can be very hard as a clinician for anyone trying to do that work. But so grateful that eventually the hospital added a position in research that I could do that 100%. But again, a lot of what I do now is guided by the clinical practice that I started off with at the hospital. I am going to share my screen for a second to kind of start us off. Hopefully. So this is, just the challenges of doing research and how long it can take. But the great thing about Ontario Shores is that because, I'm, being an internal researcher and being embedded within the hospital, I feel so lucky that we get to, that it's closer, that the research that we do seems to touch practice much sooner. And we are influenced by changes and initiatives at the hospital. So normally when this, research takes forever, that I do find that Ontario Shores, we're lucky that we are a little bit closer to actual practice and being able to influence it quicker. So, a long time ago, I thought that I was going to be a lawyer. And then I went to university and realized that's not what I wanted to do. And I fell in love with psychology and really tried to figure out how can I marry the two. So I sort of consider my research as this sort of blending of, the legal system and our mental health system, particularly in the forensic mental health system. And then more recently, I'm switching back to sort of the legal side, but within law enforcement. So again, I'll tell you about that in a second. So again, first, before I jump into like the particular projects, I wanted to show kind of what inspires me or what I think about and how I use, again, the clinical experience that I have and what's happening on Ontario Shores and the goals and values of the hospital and sort of marry that with my own research interests. And so really the big button here is I think about social justice, that from the very beginning, even when I wanted to be a lawyer, I essentially wanted to work with offenders. So I always wanted to work with populations that were either oppressed or had stigma and that other people sort of shied away from because of these things. And so I wanted to defend sort of the bad guys. And then, as I became a clinician, I initially wanted to work in corrections, again, with offenders, recognizing that I feel like our society doesn't give them a fair shot, and that, if ultimately we would like to have a safe community, that the way to do that is through support and kindness and accountability. And so again, social justice really drives really everything that I do. Again, really influences the topics that I pick for research. Oops, going the back wrong way. Okay, so again, when I started off on FPRU, I saw that that forensic folks, when they get into our system, they tend to be here for quite a long time. And the system is slow. Our entire justice system, not just the Ontario Review Board system, but the entire criminal justice system is a slow process naturally. And then there's also these other factors that influence what that progression looks like. So both from the legal perspective, so how they move through that system, sort of on the staffing side, but also from a recovery perspective. So folks who, were providing treatment and supporting their mental illness, that there's also factors that influence their recovery trajectory. And I'm sure, we've heard Simone talk about recovery and sort of what influences that process as well. One of the things that, I identified was, again, bias. So not, something that I came up with, but I looked at how can we explore bias in the system. And again, this is not meant as people sort of maliciously stigmatizing our clients, although that can happen in the community, but rather unintentional or implicit bias that seeps into the system. And I've been so lucky to connect with basically the world, like a world leader in looking at bias in forensic psychology. His name is Itiel Dror, and he looks at all the ways in which bias enters into our legal system, mostly to do with forensic science, so fingerprints and blood splatter and things like that. And he has come up with entire theories and constructs around bias of experts, and looks at how does bias actually move from one expert to the next. So that he would call that a cascade of bias, or when that happens, that cascade from one expert to the next, that in fact, the bias can sort of get bigger and multiply. And so we call that a snowball effect. So these are things that I've tried to explore in our forensic system. And one of those ways is sort of looking at the power of words. So this is a main focus of mine right now. So looking at documentation and how documentation is biased. Again, looking at that implicit or unintentional bias. So we did a lot of work looking at nursing documentation, again, with the understanding of using Itiel Dror's framework, that we know that bias can pass from one person to the next. So if one nurse writes a note and the next nurse reads that note, that cascade of bias, or for me, when I was working on FPRU, doing, let's say, a risk assessment, I would be relying on nursing documentation to provide some of that information. So now I'm making decisions and judgments about clients based on what I'm reading. So again, exploring that cascade, and then perhaps even the snowball. So now my own bias sits on top of that bias. And then, we're making decisions about clients. So perhaps that bias influences, again, how they're moving through the system. Excuse me. So right now we do have research that is sort of extending that early work that I did on nursing documentation, and I'll talk about that in a second. Again, with social justice, I feel like it's not enough to just think about it or talk about it like locally, but that in fact, social justice requires action. And, trying to think about that in my own work. And so I would say that early on in my career, that was something that I didn't do very well at. that, knowledge translation and bringing awareness raising around issues is something that I've tried to focus on more specifically in the last few years. So that's definitely something that I think about in terms of the big picture. And then, it's so lovely that, I get to sometimes collaborate with Simone when we're looking at recovery. So again, recovery is one of the factors that influence how folks move through the Ontario Review Board system, so their own personal recovery. And there's been some research by folks at CAMH that have looked at how can we have sort of use the recovery model to support folks in the forensics services, and is there other steps or other tasks that people need to engage in order to get further along that path in terms of recovery. So again, folks not just with psychiatric illness, but also involvement in the criminal justice system, that they might have extra tasks in their recovery journey that again will influence what their recovery looks like, but again also influences how they move through the system. Again, one of those concepts of recovery is engagement and connectedness and being involved. And I know that our forensic services department has tried to really focus on how do we engage our clients more and more meaningfully. And so including clients in that, in their recovery, in their journey through the system, can we include them in risk assessment? And are they good at, identifying their own risk? And so are there ways that we can include clients to participate more fully in the forensic services? Oops. And then also just how we respect and care for others. So this, again, part of what combines to make up social justice, but this is extended, I would say, a lot for me into the area of law enforcement. So how, for example, police officers interact with folks with mental illness or who are just in mental distress on calls, and how they're engaging in that process influences how justice is played out. But it also has a significant effect on the officers or other law enforcement staff mental wellness. And so I'll talk about in a second of how, I've sort of switched sides, but playing sort of both sides, that both, again, supporting our folks in the forensic system or individuals with mental illness who are involved in the legal system, but also the mental health and wellness of officers and other law enforcement staff. So before I keep going, just wanted to check in with the group. Any questions or comments about thinking about sort of the big picture that around social justice, or how you might envision how social justice plays into your work at the hospital or your role? Any thoughts, or is anyone social justice warriors out there?
I just have, it's more of a conceptual thing. It's just, I wonder if there is any interface between equity, human rights, and also what you're talking about, social justice. If you can comment on that.
Sorry, Mary, what specifically, what specifically about that are you wondering?
Yeah, so it's just, the most recent things that I've been, briefed on, I guess, is, the use of restraints and, and how is, a human rights issue. And how is that how does that even look like in the context of social justice, being able to treat these individuals in the forensics unit with with that kind of like mindset of, yeah.
Mhm.
I understand my question, but
yeah, I mean, I hope so. I'll jump in and see if I can provide a few comments. So one thought, I mean, it's interesting because again, personally, I'm not so certain what I think about the use of restraints. But that, again, like I mentioned, that at KMH, there's a team there that has written about can the use of restraints and seclusion be used in the recovery model in a way that actually supports forensic clients with their recovery, and that is it, by using those tools, are we able to actually help folks toward their own goals? So recognizing that if we have conversations with folks when they are perhaps, when acuity is lower and that they're feeling more well, in an informed consent sort of way, that perhaps we can use some of these tools when people are maybe at their worst or really struggling with mental health challenges in a way that could protect them, so that they can preserve their recovery to a degree, again, using them as tools. So that's certainly some line. It's not something, so I don't really do a lot of restraint and seclusion work, but or research, but that's some of the commentary that is out there around recovery and those use of those tools. There was something else. The second thing you said had me thinking about something. I've lost it now.
It's all right.
It'll come back to me. There's something about human rights. And I guess I was thinking about that even so some of the work that I've been partnering with Dr. Carolyn McGregor about. So and also my work, part of a larger project with our Durham Regional Police. Both projects are looking at how do we increase competence with de-escalation skills of either nurses or police officers to better respond to people in mental distress. And I think that that's our responsibility to ensure that we are using the best possible tools, or that people are extremely skillful at that, so that when they are interacting with people who perhaps might be vulnerable in that moment, that we are able to support them in the best, most respectful, procedurally just ways, that again can reduce or prevent their involvement in the criminal justice system. Like I think about clinically, I once had a young girl I worked with who self-harmed. And when she self-harmed, she lived at a group home, and her group home staff would do sort of hands-on and call the police. And then the police would come, and in their attempt to bring her to the hospital, she would violently assault the police and the group home staff. Had they not intervened, she wouldn't have assaulted them. And had she not assaulted them, she wouldn't have a criminal justice involvement. And so it was like, how do we go way back and provide really effective, competent, and respectful care to manage her mental distress, which was causing the self-harm, so that she didn't end up being involved in the criminal justice system. So I think some of this work, again, with either with Carolyn or other folks, is if we can improve the competence and effectiveness of our interventions, we can reduce the likelihood that folks in mental distress will perhaps have to enter into the criminal justice system. And again, there's another project I'll talk about in a second that is sort of similar to that, is really just respectfully and competently intervening with folks with mental illness or other types of mental health challenges, again, to prevent involvement in a place that is not really solving or supporting their needs. So again, the driver, or my inspiration, is really around social justice. And with that comes with some, and I sort of enjoy this part, I guess my personality is that it aims to be slightly controversial, or aims to be something that's going to make people uncomfortable. And invokes curiosity, hopefully, for other people. But I think that, when I tell my clients who I see in my private practice, like, look, my job is to make you slightly uncomfortable all the time, because that is where change happens. And that, if we're doing research that always feels comfortable, I think we're not quite, doing what we should be. And that research is meant to, again, inform us, but help us change and move forward and understand things so that we can make positive changes. So that does make for a bit of a rocky ride sometimes, but I appreciate that Ontario Shores has, navigated that ride with me. And so now I thought I'd just talk a little bit about some of the research studies that I have. Here we go.
Dr. Martin.
Yes.
I had a quick question about what you just talked about in regards to the cascade bias and snowball effect. So I guess maybe on a more big picture level, how do you break that chain of implicit bias when you're talking about, one nurse is doing his or her notes, and then that's, being passed on and the bias is growing? How do you break that when documentation is so common in the workplace?
Right. So let me, I'm going to put a sort of pin in that because I'm going to talk about my bias in a second, but thank you for bringing that up because it is important. So like I said, that my research is really divided into two sections. So one really is focused on forensics and the other one is in law enforcement. So very briefly, just to give you a snapshot of some of the projects, and then hopefully, again, you can think about how might this apply to what you're doing in your own role. So the first one is on restrictiveness. And I was very fortunate to attend a conference a few years ago, and I met this man named Jack Tomlin, who is a psychologist in the UK and now in Germany. And he and colleagues identified this idea around subjective restrictiveness. And I have really sort of fallen in love with this idea that, our forensic folks and folks on the other side of the hospital are all subject to different types of restrictions, both in our environment, in our policies and legislation or rules, but also by society, right? By stigma or attitudes or beliefs about especially forensics or mental illness. And so these restrictions are going to be experienced differently by each person. So for example, in our research, we asked clients, do they think they should be under the Ontario Review Board system? Because some folks think that they should be just in the regular criminal justice system and at jail rather than at the hospital. And so that was one of our variables that predicted how restricted they felt. So again, this idea that if they think it's fair that they should be at the hospital, that they're actually going to experience these restrictions as less restrictive. It may also be in terms of what privilege level they have. We also found that as they get older, so whether it's age or just how long they've been in the hospital, they're going to feel more restricted. And so again, this group in the UK, they created a questionnaire to measure this. And so we've created a Canadian version, and we've been so lucky that we've now partnered with the North Bay Regional Health Center. And so they're going to be collecting data from their forensic program too. Just after Christmas, I talked about restrictiveness at a conference related to COVID. And I think this, we've all experienced what restrictive practices feel like over the last year and a bit. And it'll depend on how restricted we feel based on, do we have a job that we can continue to go to? So for example, when I talk to all my police officers that I work with, they feel a little bit less restricted because they go to work every day still and nothing has changed, or, not as much has changed for them in that. Or whether you have, I have a client who lives downtown Toronto in a condo with no balcony. And so it feels extremely restricted, not being able to access the outside. So again, this sense of restrictiveness changes based on our experience, based on our circumstance, our access to money, outdoor space, and things like that. So I think that what I'm hoping to use this information on is to look at perhaps that restrictiveness is one of those factors that influence someone's recovery journey. So how does recovery look different in folks under the Ontario Review Board system? And I think this restrictiveness experience is one of those ways that is slightly different than perhaps if they are in the sort of civil side of our hospital. Before I go on to the next project, any questions or comments about feeling restricted, or what that's, what that might look like in terms of your own role at the hospital or even personally? Okay, if you think of anything, let me know. So the next one, again, another area that I'm super excited about from a research perspective, not clinically, it's very difficult clinically, is this sense of moral injury. And so again, at a conference a few years ago, I heard a soldier talking about moral injury. Again, this idea that sometimes when we experience a traumatic event, we don't, it's not necessarily fear that we feel after, like we would if it was PTSD, but rather shame or guilt or betrayal. So this soldier was talking about having been given a command to do something that he knew was going to kill civilians. Yes, it was in, the context of war, but how difficult that was, that he didn't feel like that matched his morals. And so, it really got me thinking about this particular client actually that I worked with on FPRU, who hadn't had a very long experience of mental illness. In fact, he reports only being ill for a couple of weeks prior to his index offense. But his index offense was so horrific that he couldn't, when he, sort of got on medication and treated, that he couldn't believe what he had done, that he literally walked around the hospital, I would say, like it looked like he was in shock. And so I worked with him for a couple of years, and he would literally just say, like, I can't believe I did that. Like, I don't know how I did what I did. And it didn't match with what he thought about himself. And it certainly didn't match his morals or values. And so rather than a fear-based response, he had this sort of injury to himself that impacted basically his soul, that, what he had done was against that. And so, this is an area that I've been really wanting to study in our forensic population. And so right now I have a PhD student at York University who has finished data collection with some of our folks. And then also we partnered with a research team at St. Joe's in Hamilton. And so they're going to be collecting data from our folks as well. And we've been really lucky to develop a moral injury and forensics community of practice in Ontario that serves as a sort of a pillar or one of a smaller group within the Center of Excellence for PTSD at the Royal in Ottawa. So again, another area that I'm really keen to focus on because no one else is really looking at this right now. I mean, certainly I'm sure some of you have heard about, maybe even heard the term moral injury lately, again, in the context of COVID because of how it's impacted healthcare workers. I think we experienced it perhaps a little bit less in Canada, but certainly in some places for healthcare workers having to make decisions that didn't feel like it matched with their oath to not, do harm. Or even here at the hospital, like for, thinking about that our clients weren't able to see their families, how hard those decisions are to make, and how that goes against our desire to care and support our clients. And those decisions are really hard and influence our well-being. So another project in this area is my interest in, again, restorative justice. So I'm very lucky that Sayeni is here today. So she has been fundamental in this project and really driving it. So again, influenced by conferences. So I get tons of inspiration when I go to conferences. But this really cool program in the Netherlands that had applied restorative justice, which really is an alternate form of responding to criminal behavior or harmful behavior, which rather than sort of having the state act as the person who's going to get justice, that it is a more collaborative program that brings the offender, the victim, and the community or any other stakeholders together to actually repair harm. When we send someone to jail, it doesn't really repair any of the harm, except perhaps, the desire for retribution. But, victims or the community is still at a loss for how to pick up the pieces after. And so I think that, this is incredibly interesting in terms of the forensic system because, research has shown that there's this belief by Canadians and other folks that there's even less justice when someone is found not criminally responsible, and they misunderstand our Ontario Review Board system, and that they feel like there wasn't any punishment or that people are getting off easy. And so I think there's even more room here for bringing in victims and stakeholders in the community to better understand the review board system, to understand mental illness, and so to actually engage in practices that could restore the harm, for the mental health of victims and the community and offenders. So right now we've just completed and are going to submit this week, so yay, our scoping review of restorative justice practices in forensic mental health settings, with the hope that we will then move forward with exploring how we could perhaps bring this to the hospital. And I think this fits really well for anyone who is aware of the FIT initiative. So the family therapy that we know is one of the gold standard pieces of supporting and treating folks with schizophrenia. So I think that, again, even outside of the forensic system, that there often is harm that can happen between, especially family members, for folks who might have severe mental illness. And so if we could bring in some of the concepts with restorative justice, that will actually restore or could support anyways the family initiatives, that between families. And then the last one, so I know there was a question, thank you, about my bias research. So again, I talked a little bit about this already, but the question around, well, what do we do about bias if it's implicit? And certainly I have the police asking me this regularly, because there was just an inquiry report that was published about the Toronto police, that one of their recommendations was to have police, not sort of like police candidates, be screened out for certain types of bias. And certainly I think that can happen if it's explicit, but implicit bias is very hard to first identify within yourself, hence it's implicit, but also for us to identify it and then do something about it. So really again, looking at sort of the work that Etiel Dror has done at what do we do about this if it is on an implicit level, that mostly what it is again, first acknowledging that it is there, that we are all subject to it, and it's just part of the human condition. So we all have bias. So again, just, people are saying, well, I'm not biased, I don't have this, or especially, in the last year talking about racism, people not quite understanding that much of that could be implicit. And so we may not have full awareness about ourselves. So it's really about setting procedures and practices in place that would help us catch ourselves. So for example, our hospital is, known for and has really done a fantastic job about creating an electronic health record. And so we could use AI practices, or we could use the way that, our electronic system is set up to perhaps catch words that are biased in nature. So some research that I published in the past is on particular words that could be biasing. So for example, the difference between, client or patient refused breakfast versus patient, did not eat breakfast, right? So the word refused means something very different than, they chose not to eat breakfast, or, patient denied having, hallucinations versus a patient who stated they did not have them, right? So there are certain words that we've identified that actually influence how we think about patients. And so could we use our electronic health record and technology as a way to catch ourselves in documentation. That's sort of one area where we could sort of catch the bias. Another way that we know is helpful is really team decisions. So, I mean, we have to be careful of things like groupthink, but having multiple perspectives. And so this is where, again, in forensics, that perhaps, there's been an effort to do team decisions on risk assessments rather than having one person do them. And so we have the nurse or a social worker and a psychologist and psychiatrist all involved. And then that can help catch perhaps any biases or bring to light different perspectives that would help us, perhaps not avoid bias because that's going to be there, but reduce it in general. So right now we have a study where we are actively recruiting nursing staff across the hospital to do a study. So I'm hoping that we can get that finished soon. All right, so I'm just going to shift. And like I said, that a lot of my research was really focused on our forensic folks, how we can support staff, including law enforcement officers, to respond better to folks in mental distress. And then that really opened up a whole other world for me in terms of, the mental health of first responders. And so I have three main projects that I'm doing right now. And this one of them is with, well, they're all with Durham Region Police, but one of them is called their VPOP program. And so again, this kind of goes back to that social justice piece where what it was is that they had a police and nurse partner groups who would not, like right now they do have a program where it's a co-response to calls where people are in mental distress. But this was actually an additional program where we received funding to have this police and nurse partner actually go out proactively into the community where either police officers or community support services or other people could call in and say, I think this person needs support. I think they need services or to be connected to services. And so they would proactively engage with folks in the community to try to get them connected to, CMHA or Durham Mental Health Services, or could they get them connected to victim services? Again, with the idea that too often people with mental illness are unnecessarily pulled into the criminal justice system, that really what they need is support and care and treatment. And so it was an effort to help folks connect to services, again, prior to being involved in the criminal justice system. So right now I have an evaluation of this program that's going on. A big, huge project that's taken up a lot of my time over the last 3 years has been this DRP support program. So we received funding to create an app that supports the mental health of all DRPS staff, so sworn and civilian staff. And so, again, that just got launched this year. We're in the evaluation phase of it to see what officers and other civilian staff think about it. And, be able to feed back to the Ministry of Labor, who provided us the grant, information on hopefully being able to scale this up to other services. So for example, just yesterday, I spoke to a service, the Delta Police Service in BC, and they're looking at perhaps using our app. And then the final study that I have going on right now in regard to first responders is been sort of a pet project of mine for quite a long time. The hospital, again, super supportive about this initiative where, again, recognizing that first responders, they are desperately in need of mental health support, and that when they go to access this in the community, there's not a lot of clinicians who specialize in this area or who are willing to, not a lot who specialize in trauma, and who know much about the sort of cultural uniqueness of these groups. And so we have a pilot project that's a collaboration with Wounded Warriors called the First Responder Assist Program. And so there's clinicians from Ontario Shores that are embedded at Wounded Warriors who provide one-to-one therapy for first responders. And so we have an ongoing evaluation of this right now. Okay, so in the last few minutes, I want to leave some time for questions, but also for, again, thoughts or comments or suggestions about where you see this kind of work perhaps applying to your own area within the hospital, overlapping with some of your clinical work or research work, or where you think that it could be, like what would next steps go? So I'll just open it up there for a second. Any questions, thoughts?
I just, I guess I'll just start the conversation. One of the, I know you have been spending a lot of time on the app, and it's just starting to like rack up the accolades, and the impact of it is so widespread, and it's racking up the accolades that it is worthy of your effort. And it's I just and I'm so glad that like it didn't stop there, right? So like the knowledge translation and the knowledge mobilization is ongoing, even so like the app is not the end product, but rather it's like how do you, now you have this, how are you going to adapt it into the group in BC now, right? So it's just going to continue to grow that way.
Thank you, Mary. Yeah, I mean, it's interesting because the app is just a vehicle. It's not anything fancy. And what the app does, I think even more so, is just gets people to think about mental health among first responders. So that alone, those conversations have been helpful. And it's just, again, reducing barriers to accessing care. So a lot of what we've, our actual research is not even about the app, like related to this project, but related to what are the barriers to help seeking, what types of information do law enforcement think is important for their mental health, and like what gets in the way of them, or sort of where do they get their help? So yes, some of them are accessing care, but we see, for example, that police officers are more likely to be willing to access care within the organization, whereas civilian staff who actually report just as much or more mental health challenges are less likely to access care from within organizations. So there's a lot of sort of policy or organizational knowledge that we've gained from this project that, again, will feed back to the ministry and they can use that. So again, I think the app isn't fancy, but it's actually the information that we've learned as a result of creating the app and doing so much co-design. So the first round of co-design, we had, probably about 270 GRPS staff have input into the app. And now we're in the evaluation stage where we're going to have another 50 people in focus groups giving feedback. So it's that information that is the most important, really, to be shared with other services.
For sure. Do you find, my, like personal kind of interest or like target population is caregiver and family members. So I think, like a lot of the themes that are, how do you navigate the support system when you have these issues? And it applies to, more broadly, like and beyond the police first responders population, obviously, and and obviously they do have like specific needs and challenges as well in their profession, but like a lot of maybe like there are some commonalities that can be shared with the other population as well.
And you bring up a good point. I mean, we know from research that actually a person's loved one is the most important support person for officers, specifically with regard to PTSD outcomes. And so right now we're unable to provide the app to loved ones, but I think about that it's your loved ones or your family who recognize, I think, those signs early and perhaps even earlier than you might. And then if you are really unwell, those are the people who are navigating the system for you. And it's really hard to do when you're unwell and stressed and all of that. So I think it'll be really important for us in sort of the phase 2 or phase 3 of this project to figure out how can we get this app into the hands of loved ones. So we'll see.
Wonderful.
Any other last questions or ideas? Again, so like I said, our hope with the app is to be able to expand it to other services, but also to, like I said, family members of TRP staff. With the bias research, my hope is that we can influence nursing onboarding and education. So I know that there's interest across the hospital to influence mental health curriculum in nursing. So perhaps we can also integrate some of what we've learned around documentation and bias in that work. And then the other one, which I mentioned, is really because of the standards of practice with FIT, or like the family interventions with schizophrenia, that I think that this restorative justice piece is something that I'm hoping that we can sort of marry to that family work, that even in a non-criminal or forensic setting, that sometimes people with mental illness, that there's harm that is done between family members or even the community. And so is there a way that we can do repair the harm that may have been caused between the community or loved ones and some of our folks in a way that promotes individual recovery, but also the community's like stigma and how our folks are sort of welcomed back into the community once they leave our walls. So I will leave it there, but I so appreciate everyone coming and listening to all of my stuff. And I really hope that if you have any questions or want to be involved in any of this or have any suggestions, that reach out to me, because again, I think that it's my perspective of my clinical practice that influenced this so much. And so I would love to hear from other people.
Thank you so much, Dr. Martin.
Thanks, Mary.
Thank you, everybody, for coming. And Kushi is saying thank you. Oh,
yay. Thank you.
Wonderful. Great. Okay, so we'll end it right here, and then wishing everybody a good afternoon.